Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing a very important topic in the cardiology, that is the mitral valve prolapse. So mitral valve prolapse, what will be the way by which the individual is diagnosed is, they have a very important auscultatory finding, that is a mid-systolic click with late systolic murmur. That is a classical auscultatory finding in patients with the mitral valve prolapse. And most of the times what exactly is the etiology is not known. It is idiopathic, but you can also come across this mitral valve prolapse in connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta. These are the hereditary connective tissue disorders in which you can come across this mitral valve prolapse. And not only connective tissue disorders, even this mitral valve prolapse can be associated with rheumatic fever. It can be associated with ostium secundum type of ASD. And most of the times these patients with mitral valve prolapse, they are asymptomatic, right? And if at all, if they are symptomatic, the most common symptom will be palpitations. And these palpitations are mainly because of the development of arrhythmias or ventricular premature contractures in patients with the mitral valve prolapse. Now, what is the criteria to call it as mitral valve prolapse, or what exactly is the definition of the mitral valve prolapse? And how will you diagnose mitral valve prolapse? And what is the management in these patients with the mitral valve prolapse? All that we will be discussing in this session now. So now if you take the basic criteria or the definition of the mitral valve prolapse. So whenever the left ventricle is contracting, the mitral valve leaflets, that is anterior and as well as posterior mitral valve leaflets, they prolapse into the left atrium. So once they prolapse into the left atrium, what should be the distance between the mitral valve annulus and as well as cusp, which has bulged into the left atrium? So if you see this distance, it should be 2 mm, right? The cusps, they have to bulge into left atrium from the mitral valve annulus by 2 mm. So that is a very important criteria to call it as the mitral valve prolapse. And this mitral valve prolapse, it has been given multiple names, multiple terminologies are there for mitral valve prolapse. And what are those multiple terminologies? That includes, number one, it is the systolic click murmur syndrome. Why is it called systolic click murmur syndrome? Because just now we were discussing mitral valve prolapse, the very important auscultatory finding is these individuals, they will have the presence of the mid-systolic click with late systolic murmur. Okay, so this is the reason why it is called systolic click murmur syndrome. And another name for this mitral valve prolapse, this is also called as the Barlow's syndrome. Now, why is it called Barlow's syndrome? Let me try to explain to you with an image. Now, you see, this is the image of all the valves, right? This is the pulmonary valve, aortic valve, then mitral valve, and then tricuspid valve. So out of which you take the mitral valve. So within the mitral valve, like what is that you have is, you have an anterior mitral leaflet and then the posterior mitral leaflet. Okay, AML and as well as the PML. These are the two important leaflets. Now within the anterior mitral leaflet and posterior mitral leaflet, again you have the presence of the cusps, right? Again you have the presence of cusps for these mitral leaflets. So you take the anterior mitral leaflet, the cusps are A1, A2 and as well as A3. Whereas for posterior mitral leaflet, we have P1, P2 and as well as P3. So these are the cusps within the AML and as well as the PML. Now let me try to explain to you why is it called Barlow's syndrome. Most of the times what will happen is the cusp of the posterior mitral leaflet will prolapse into the left atrium during the LV systole. But why is it called Barlow's syndrome is, if multiple cusps, right, if multiple cusps of the mitral valve leaflets, if they prolapse into the left atrium, then we call it as the Barlow's syndrome. Okay, so the another name for this is Barlow syndrome. Why? Because if multiple cusps of the mitral valve leaflets, if they prolapse into left atrium during LV systole, then we use the word called as the Barlow syndrome. So most of the times, which particular cusp or which particular leaflet will prolapse into the left atrium during the LV systole? It is the posterior mitral leaflet. And within the posterior mitral leaflet, again, you have like P1, P2 and as well as P3. So it is the middle cusp of, right? So it is the middle cusp of posterior mitral leaflet. Okay, so that is the one which will prolapse into the left atrium. That is the most common cusp which will prolapse into the left atrium. So that is why it is, that is what happens in mitral valve prolapse syndrome. But in Barlow syndrome, multiple cusps will prolapse into the left atrium. Now, another name for it is floppy valve syndrome. Now, why is it called floppy valve syndrome? That is because if you take the basic pathology or pathogenesis in patients with mitral valve prolapse, it is the myxomatous degeneration, or there will be defect within the connective tissue within the mitral valve, and thereby the mitral valves, they become very floppy, and that is the reason why it is called floppy valve syndrome. Next is, why is it called billowing mitral valve leaflet? See, if you take the English meaning of the word billowing, the word billowing means something floating in the air. That is what is called the billowing. Now, what is happening here? In these patients, the mitral valve leaflets, they are like floating in the left atrium. That is the reason why it is called as the billowing mitral valve leaflet syndrome. So these are the four important terminologies which are given for the mitral valve prolapse. Now, let me discuss about the basic pathology, what happens in the mitral valve prolapse. So, commonly associated pathology is, right, the most common associated pathology within the mitral valve will be myxomatous degeneration, right? And there will be abnormal excessive accumulation of the glycosaminoglycans. So there will be increased concentration of the glycosaminoglycans. What are these glycosaminoglycans? These are basically a complex form of the carbohydrates. So these carbohydrates that will be mainly in the form of disaccharides. These disaccharides, they combine with the amino acids, okay, and these glycosaminoglycans, they get excessively accumulated within the mitral valve, causing the degeneration of basic structure of the valve. That is another important pathology that happens within the valve. And another important abnormality within the mitral valve prolapse is reduction in the production of reduction in the production of type 3 collagen has been implicated for the development of the mitral valve prolapse syndrome. Now, if you do an electron microscopy, right, if you observe the mitral valve under the electron microscopy, what has been revealed is there has been fragmentation of collagen fibrils. Right, there has been fragmentation of the collagen fibrils. That is what will be the electron microscopic picture in case of the mitral valve prolapse. Now, that is about the pathology. 1, myxomatous degeneration. Number 2, excessive accumulation of or increased concentration of glycosaminoglycans, and reduction of type 3 collagen within the mitral valve. Now, let me discuss the etiology of the mitral valve prolapse. So, if the question is asked, like, what is the most common cause of mitral valve prolapse syndrome? The most common cause of the mitral valve prolapse syndrome, like, the etiology is not known. It is idiopathic, right? The cause is not known. And apart from this idiopathic, what are the other causes which are associated with the development of mitral valve prolapse is, they are heritable disorders of the connective tissues. So what are those heritable disorders of the connective tissues? That includes Marfan syndrome, right? Number 2, osteogenesis imperfecta, right? Osteogenesis imperfecta, right? And number 3, it is Ehlers-Danlos syndrome. Right, number 3, it is Ehlers-Danlos syndrome. So these are the 3 important heritable disorders of the connective tissue. Now, even the development of this mitral valve prolapse we have some cardiac causes as well. So what are those cardiac causes that can cause, that is associated with the mitral valve prolapse syndrome is, number one, acute rheumatic fever, right? Number two, in almost 20% cases of ostium secundum type of ASD, right? In 20% cases of ostium secundum type of ASD, like there can be associated mitral valve prolapse syndrome. Next is the ischemic heart diseases, they are associated with mitral valve prolapse syndrome, and cardiomyopathies, right? They are also associated with the development of mitral valve prolapse syndrome. Okay, so these are all the etiologies which are responsible for the development of MVPS, out of which the most common cause will be the idiopathic. Now, because your mitral valve prolapse syndrome is associated with the connective tissue disorders like Marfan's, right? In these patients with mitral valve prolapse syndrome, they have associated skeletal deformities, right? So what are those associated thoracic skeletal deformities that you come across in the mitral valve prolapse? You take in Marfan's, like how will be the palate in these individuals? These individuals, they have high arched palate, right? They have the presence of the high arched palate. Okay, number two, there will be alteration in, right, there will be alteration in chest, and there will be also alteration in the thoracic spine. And in these patients, they also have another important abnormality which is called as the straight back syndrome. So these are the associated skeletal abnormalities that you come across in patients with the Marfan syndrome, right? Now, because the individual is having associated Marfan's, they also have the joint abnormalities. So in Marfan's, like how will be the joints? There will be hyperextensible joints, and there can be also joint dislocations because of the abnormality within the connective tissue. And how will be the menisci? Either you take the medial menisci or lateral menisci within the joints, you will also have associated meniscal tear, right? You also have associated meniscal tear. And even the skin, right, it is very loose and fragile. So these individuals, they have easy bruisability, right? These individuals, they also have easy bruisability. And you take the inguinal canals, right? You have the support system for the inguinal canals that will prevent the development of the hernias. Now, in patients with Marfan's, because of the connective tissue disorder, the support system for the inguinal canals are lost, and that is the reason why these individuals, they are also having associated inguinal hernias. Okay, so these are the abnormalities that will be associated in patients with the mitral valve prolapse if they are having associated Marfan syndrome, right? Now, what is the very important valvular abnormality that you come across in patients with the mitral valve prolapse syndrome? So the most common valvular abnormality in case of the mitral valve prolapse is the mitral regurgitation. So in these individuals, most commonly the myxomatous degeneration is present within the mitral valve, but occasionally the myxomatous degeneration can be there within the tricuspid valve, and myxomatous degeneration can be there even within the aortic valve as well in these patients with the mitral valve prolapse syndrome. So, but remember, for the development of the mitral regurgitation, the most common cause of primary MR will be the mitral valve prolapse. Okay. Now, what is the mechanism of the development of mitral regurgitation in case of mitral valve prolapse? Let me try to explain to you that. So, in these patients, you see this is the structure of the mitral valve apparatus, in which you have the mitral valve leaflets. These are the commissures, that is medial and lateral commissure. Then you have the chordae tendineae, which are connected to the papillary muscles, and this papillary muscle is connected to the endocardium of the heart. Now, whenever the mitral valve, it is prolapsing, right? Whenever the mitral valve is prolapsing. So how much? This should be minimum of 2 mm. So when the mitral valve is prolapsing into the left atrium, the mitral valve leaflets are connected to the caudate tendineae. So what happens to this caudate tendineae is, these caudate tendineae, they become elongated whenever the mitral valves are prolapsing into the left atrium, and they become redundant, and at one point of time they get ruptured, right? At one point of time the caudate tendineae, they become ruptured. So the ruptured caudate tendineae, that will contribute to the development of the mitral regurgitation. And the next important point is, these caudate tendineae are connected to the papillary muscles. So what will happen to the stress on the papillary muscles? There will be excessive stress that will be there on the papillary muscles, and this excessive stress on the papillary muscles will cause the papillary muscle dysfunction, right? Will cause the papillary muscle dysfunction, and it will also cause the ischemia of the papillary muscle, right? It will also cause the ischemia of the papillary muscle, which is connected to the ventricular myocardium. Now this particular part of the ventricular myocardium, right, this part of the ventricular myocardium or endocardium, which is connected to the papillary muscle, this part will undergo the regional dysfunction, right? This part will undergo the regional dysfunction, and this part will undergo fibrosis. Okay, so this part of the endocardium has the tendency of arrhythmogenicity. So this part of the endocardium will throw arrhythmias, where the individual will develop the ventricular premature contractures, right? Or these individuals, they develop VT or VF subsequently. So there will be excessive stress on the papillary muscle, causing dysfunction and as well as the ischemia of the papillary muscle. The part of the endocardium where the papillary muscle is being connected, that also becomes the ischemic and fibrosed, and that will be arrhythmogenic, due to which the individual will develop VPC, VT or VF. And so this papillary muscle dysfunction also contribute to the development of mitral regurgitation. See, once these papillary muscles, once they rupture from the endocardium, the entire mitral valve apparatus, it will flow or it will prolapse into the left atrium, causing mitral valve prolapse syndrome. And not only the ruptured caudate tendineae and the papillary muscle stress, even this annular dilatation also occur, right? Even the mitral valve annulus, that is also being dilated, and this mitral valve annulus is also being calcified. So the annular dilatation and as well as calcification, that also contributes to the development of the mitral regurgitation. Okay, so these are the three important mechanisms by which there is development of mitral regurgitation in patients with mitral valve prolapse syndrome. Next is the clinical features. Most of these patients, remember, they remain asymptomatic, right? Most of these patients, they remain asymptomatic, and this mitral valve prolapse syndrome, it is more common in women rather than men in the age group of 15 to 30 years, right? It is more common in females rather than males. But whereas you take in elderly individuals of age group more than 50 years, here it is more common in men rather than women, right? And these patients, they also have associated development of the mitral regurgitation secondary to rupture of the caudate tendineae. And these mitral valve prolapse syndrome, it is a familial disorder, and there is a chance of inheritance. And the inheritance that you come across in patients with mitral valve prolapse syndrome is the autosomal dominant form of inheritance with incomplete penetrance, right? So it is not complete penetrance, it is incomplete penetrance. So what did we discuss? Most of these times, the individual, they remain asymptomatic. But if at all, if they develop the symptoms, the most common symptom or the most common clinical feature will be the palpitations. Now, why is that these patients, they develop palpitations? Just now we have discussed the papillary muscle, it undergoes ischemia and dysfunction because of the excessive stress, and the subjacent endocardium, it also becomes ischemic and fibrosed. Ischemic and fibrosed endocardium will be arrhythmogenic, and that will shower a ventricular premature contracture, VT or VF, and that contributes to the development of the palpitations. So palpitations, they are the most common clinical presentation in these individuals. Okay, and the next important point is the chest pain. But this particular chest pain, what these individuals develop, right, it simulates the angina pectoris. It simulates the angina pectoris, but what exactly is the cause of the chest pain is not known. And where exactly will be the site of the chest pain in these individuals? That will be in substernal location, right? And the pain will be for a prolonged duration of time. And this particular pain, it is not related to exertion. But you take in case of the angina pectoris, the pain increases on exertion. But here, the pain does not increase with exertion. But the quality of the pain will be similar to that of the angina pectoris. Now, so very important symptom is what? The palpitations. And we have discussed what is the cause for palpitations. So either it is VT or VF or ventricular premature contractures, or even because of the atrial fibrillation, because these patients are developing mitral regurgitation. So once there is mitral regurgitation, what will happen to the dimension of the left atrium? The left atrium dimension increases. So the distended left atrium will be arrhythmogenic, and thereby the individual will develop atrial fibrillation. Okay. Now, so once these individuals develop the arrhythmias, so what will happen, right? Once these individual develops arrhythmias, what will happen to the cardiac output? So cardiac output of the individual will be decreased in case of VT or VF. So once the cardiac output is decreased, what will happen to the cerebral perfusion? There will be decrease in the cerebral perfusion. So once there is decrease in cerebral perfusion, that will cause the lightheadedness and as well as the syncopal attack. Right, that will cause lightheadedness and syncopal attack. And the another rare presentation that you can have in case of mitral valve prolapse is the sudden death. But in which group of individuals you can have a sudden cardiac death? So sudden cardiac death, it is seen in those individuals with severe mitral regurgitation with depressed LV function. Right, it is seen in severe mitral regurgitation with depressed LV systolic function. So these group of individuals are at increased risk of the sudden cardiac death. Now these patients, some of them, they also develop CNS manifestations, and these CNS manifestations will be in the form of the transient ischemic attack. Why is that they develop transient ischemic attack? That is secondary to the emboli. Okay, and why there is emboli here? So one of the complication is these patients, they developed the atrial fibrillation. Atrial fibrillation, whenever is there will be stasis of the blood within the atria, there will be thrombus formation, and that can shower a thromboembolic stroke. And the other reason why there can be emboli is it is secondary to the infective endocarditis. See, these prolapsed mitral valves, they are at risk of development of infective endocarditis. And how are these infective endocarditis vegetations? These vegetations, they are right, these vegetations, they are friable vegetations. So these friable vegetations, once they rupture and enters into cerebral circulation, the patient will develop the transient ischemic attack. So these are the CNS manifestations that you can come across. So what are the complications finally in case of mitral valve prolapse syndrome? Number one, mitral regurgitation, right? Number two, development of the infective endocarditis. There can be arrhythmias. Right, and these arrhythmias, they start from the ventricular premature contracture, VT, VF, and even there can be development of the atrial fibrillation. And there can be also transient ischemic attack, that is because of the emboli entering into the cerebral circulation. And rarely what we have discussed, there can be sudden cardiac death. This is very common in patients with severe MR with left ventricular ejection fraction being grossly reduced. So these are the clinical features and complications that you can come across in patients with the mitral valve prolapse. Now, coming to the very important point, that is the auscultation, right? So auscultation is very important part of the examination in patients with the mitral valve prolapse syndrome. So in the systole, right, between S1 and S2 is your systole. So exactly in the mid part of the systole, you will listen a mid-systolic click. Now, what is the mechanism for the development of this mid-systolic click? And these mid-systolic click, whatever is there, like you have multiple mid-systolic clicks of variable intensities, right? Of variable intensities. Now, what will be, right? So, what will be the duration between the S1 and as well as the development of the mid-systolic click? So, this mid-systolic click, it develops after 0.14 seconds after you listen the first start sound, right? After you listen this first start sound, after 0.14 seconds, you listen this mid-systolic click. Now, what is the mechanism? See, how are these chordae tendineae? The chordae tendineae, they are right grossly stretched. When the mitral valve, right, when the mitral valve, it is prolapsing into the left atrium, the chordae tendineae are like stretched. The chordae tendineae are elongated. The chordae tendineae are being pulled. So, at one point of time, these chordae tendineae, which are being stretched, they become suddenly tensed. So, sudden tensing, right? Sudden tensing of excessively stretched chordae tendineae is the one which contribute to the development of a mid-systolic click. And there are multiple chordae tendineae here. So, there is sudden tensing of multiple chordae tendineae. So, that is the reason why you have a multiple mid-systolic clicks. Now, after this particular click, what can happen? The blood, from the left ventricle, it can regurgitate back into the left atrium during the LV systole. So, thereby you get the late systolic murmur. So, another very, very important part of the examination is the presence of the late systolic murmur. Now, what is the characteristic features of this late systolic murmur? So, this late systolic murmur, right, it is a high-pitched murmur. It is mid to late systolic murmur. It is, the character is, it is of crescendo decrescendo pattern, right? The character is crescendo decrescendo pattern. And where is it heard? It is heard at the apex of the precordium, right? It is heard best at the apex, and usually it is crescendo decrescendo. Occasionally, right, this murmur, it has whooping or of honking quality. So, that is about the quality of the murmur. Then what about the radiation of the murmur? See, this murmur radiation, it depends upon which leaflet has been prolapsed. So, is it like posterior mitral leaflet which is being prolapsed, or is it anterior mitral leaflet which is being prolapsed? Now, if you see, so you take the first, that is the PML prolapse. What did we discuss? The most common leaflet which will be prolapsed is the PML. So, if the posterior mitral leaflet is being prolapsed, what will happen to the jet of the MR? So, if you see this jet of the MR, this jet of the MR, it is directed anteriorly, right? Jet of the MR, it is directed anteriorly, and the murmur, it will radiate to the base of the heart, right? The murmur, it will radiate to the base of the heart when the posterior mitral leaflet is being prolapsed. Whereas, if you see, like in the scenario where the anterior mitral leaflet is being prolapsed. So, when the anterior mitral leaflet is being prolapsed, where will be the direction of the jet? So, here the jet of the MR, it is directed posteriorly, right? The jet of the MR, it is directed posteriorly, and the murmur, it will radiate to the axilla, right? Murmur will radiate to the axilla and as well as the back. Okay, if the anterior leaflet is being prolapsed. So if posterior mitral leaflet is being prolapsed, the murmur, it will be radiating to the base. If the anterior mitral leaflet is being prolapsed, the murmur, it will be radiating to the axilla and as well as the back, right? So this is about the radiation of the murmur. Now, dynamic auscultation is very, very important in these individuals. So, what are the conditions or what are the maneuvers where the click and murmur is being delayed? So, the click and murmur is being delayed by maneuvers which will increase the LV volume. So, what are the maneuvers by which you can increase the LV volume, that is in squatting position, right? Or when the individual does the isometric exercises in the form of the hand grip. Okay, so in these scenarios the LV volume is increased. So when the LV volume is being increased, the click and murmur is also being delayed, right? And what are the scenarios or whatever the maneuvers where the click and murmur will be early? So in maneuvers where there is decreased preload causing decrease in the LV volume, so in these scenarios the click and murmur will be early. So what are those maneuvers, right? Upon standing, the click and murmur will be early. And next is on doing Valsalva maneuver. By doing Valsalva, what will happen to the intrathoracic pressure increases. So that will decrease the venous return and that will decrease the preload. So please remember, any maneuvers which will decrease the preload, the click and murmur will be early. And any maneuver which will increase the LV volume, the click and murmur will be delayed. So these are the two important dynamic auscultatory findings in case of mitral valve prolapse you need to remember. Now coming to the investigations. So what are the very important investigations are ECG, the 2D echo, that is transthoracic echocardiography, and transesophageal echocardiography are very, very important. And 3-dimensional echocardiography is also very important. Next is MRI. Next, left ventriculography. So these are some of the investigations which are important. Now, first let me take up the discussion of the ECG. So ECG, it will show you that there is T-wave inversions in 2, 3 and as well as AVF leads. Now, why is that? Because these 2, 3 AVF, they bring the electrical activity from the inferior wall. And where are these papillary muscles? The papillary muscles are also present in the inferior wall. So in these individuals, whenever there is papillary muscle dysfunction causing the endocardium dysfunction and as well as ischemia, thereby you will have T-wave inversion in the inferior leads, that is in 2, 3 AVF. And occasionally you can have the ventricular premature contractures whenever there is development of the arrhythmia from the arrhythmogenic focus. And the ECG may also show VT-VF and as well as the AF as well. So AF will develop whenever there is severe MR causing distended left atrium. So that is about the ECG finding. Next is the transthoracic echocardiography. So first and foremost, very, very important is the reason why we do transthoracic echocardiography is the 2D echo will show you the abnormal position of, right, it will show you the abnormal position of the mitral valve leaflets, and it will also demonstrate the prolapse of the mitral valve leaflets into the left atrium during the LV systole. And what is the criteria we have discussed? That is, whenever the mitral valve leaflets are prolapsing, right, so this prolapse should be around 2 mm from the mitral valve annulus, right, during the systole. And this can be demonstrated in parasternal long axis view of the 2-dimensional echocardiography. So either one leaflet is being prolapsed or both the leaflets can be prolapsed. And the next important in the 2D echo is you need to apply or you need to do a color flow Doppler or a continuous wave Doppler. So by doing the color flow Doppler or the continuous wave Doppler, what is the advantage is, if there is development of MR, that can be demonstrated by doing this color flow Doppler and the continuous wave Doppler. Now, how will be the MR jet? See, whenever there is mitral regurgitation, there are two forms of jet. One is the central jet, where the leaking blood from LV to LA will be through the center of the mitral valve leaflets. Whereas another form of jet is the extrinsic jet. So extrinsic or eccentric jet, it is not through the center, it is through one side of the left ventricle. And in case of mitral valve prolapse syndrome, the MR jet will be eccentric, right? The MR jet will be eccentric in case of the mitral valve prolapse causing the mitral regurgitation. And not only that, we will be also able to make out the MR volume, right? And we will be also able to make out the effective regurgitant orifice area, right? We will be also able to make out effective regurgitant orifice area. So that is the advantage of doing the two-dimensional echocardiography. And the next important is the 3D echo and as well as the MRI. So three-dimensional echocardiography and as well as the cardiac MRI imaging, what is the purpose of doing this? These two, they provide more precise determination of, right, more precise determination of the LV volumes. That is the purpose of doing a 3D echo or the cardiac MRI. And the next one is transesophageal echocardiography. See, what is the indication for TEE is, TEE will provide more accurate anatomical information. Right, more accurate anatomical information of the mitral valve leaflets. And we do TEE before planning of the mitral valve repair. Okay, so this TEE will do an intraoperative guidance during the repair. The intraoperative guidance will be provided by the transesophageal echocardiography. Whenever you are doing the mitral valve repair, right, we use this transesophageal echocardiography. This will provide intraoperative guidance of the mitral valve repair. Then next is the exercise testing. Now, what is the purpose of doing the exercise testing is, this can be performed when there is uncertainty regarding the functional capacity of the individual. Right? When there is uncertainty about the functional capacity, then you need to do the exercise testing. So what you have to do is, it is often combined with the resting transthoracic echocardiography. That is before the stress, like before doing the exercise, you need to do a 2D echo. And after the exercise, immediate exercise, you need to do a transthoracic echocardiography. Then you should assess the RV and as well as the LV function. So this is being done whenever there is uncertainty about the functional capacity of the individual. Next is the left ventriculography. So this left ventriculography is done at the time of right and as well as the left heart catheterization. So left and as well as right heart catheterization, we do left ventriculography. Actually, it is rarely required. What it shows basically, it will also demonstrate the prolapse of the leaflets into the left atrium, right? So that is what is your left ventriculography. But this is being rarely done. Definitely it's a confirmatory test, but this is being rarely done because it's an invasive procedure. Okay, right. So this is about the investigation. So what do you think is the first line investigation now? That will be two-dimensional echocardiography, right? That will demonstrate the prolapse, that will demonstrate the MR, that will demonstrate the regurgitant volume, that will demonstrate effective regurgitant orifice area. So everything can be demonstrated in the 2D echo, right? But during the intraoperative repair, you require transesophageal echocardiography. Next, coming to the treatment in patients with mitral valve prolapse, these patients, drug of choice will be beta blockers. Because what is the most common symptom, if at all, if the individual is symptomatic? That is palpitation. Why is that due to? That is due to ventricular premature contracture or VT. So that can be subsided by giving the beta blockers. Now, what about the infective endocarditis prophylaxis? Do they require infective endocarditis prophylaxis? Yes. But what is that indication? If suppose, if there is past history of infective endocarditis, in those you need to give the infective endocarditis prophylaxis. Okay, and the advantage of giving beta blockers is it will reduce the palpitations, and these beta blockers will also reduce the chest pain in the patients. So that is the advantage of giving the beta blockers. Now what about the supplementation of the anticoagulants? See, anticoagulants are prescribed in those individuals who are having AF, okay, because in these patients with AF, one of the complication is thromboembolism. So to prevent the thromboembolism, you need to give anticoagulants. But for giving the anticoagulants, you need to do CHA2DS2 VAS scoring system. And if this CHA2DS2 VAS scoring system, if it is more than or equal to 2, that's an indication for giving the anticoagulant, that is either low molecular weight heparin if the individual is admitted, or if the individual is discharged, you can give the warfarin. Okay, so that is about the anticoagulation when you have to give. Now, what are the indications of the mitral valve repair? Right? If these patients with mitral valve repair are having mitral regurgitation and that too symptomatic MR. So what will be the symptoms of MR? These patients, they develop left ventricular dysfunction causing dyspnea. And these patients, they also can have the palpitations. So if the individual is having MVP with severe MR and that too the individual is symptomatic, then they are the ideal candidates for the mitral valve repair. Okay. Now, what is the other indication? If suppose because of mitral regurgitation, if the individual has developed the heart failure with reduced ejection fraction secondary to MR, right? The ejection fraction is reduced to less than 50%. That is also the indication for the mitral valve repair, right? Then now we have two options in the interventions. One is mitral valve repair and the other one is the mitral valve replacement. Right, the other one is mitral valve replacement. Now, which is better between these two? Right, which is better between these two? Between your mitral valve repair and as well as mitral valve replacement, mitral valve repair, that is being preferred over the replacement in patients with mitral valve prolapse or the flail mitral leaflets. Okay. Now, if suppose, if the individual is having isolated posterior leaflet prolapse, then there is no problem. You can comfortably do mitral valve prolapse, comfortably do mitral valve repair without any problem. But if there is complex pathologies, if there is like anterior leaflet prolapse, if there is bilateral prolapse, or if there is Barlow's deformity, this require the advanced skills while doing the mitral valve repair. If it is only posterior leaflet, then there is no problem, right? And whenever you are doing this mitral valve repair, what is that we have discussed? What is the investigation which is required? That is transesophageal echocardiography is very, very important component in patient evaluation and as well as the surgical planning. Now, in those individuals who are at risk of surgery, right? That means the individual is not an ideal candidate for surgery. In them, you need to do what is called TEER. What is this TEER? That is transcatheter. It is not open bypass type. It is transcatheter edge to edge repair. That is what is called as the TEER. So here, this transcatheter edge to edge repair, what do we use is, we use a clip, and this particular clip, this will grasp, right? This will grasp anterior mitral leaflet and it will also grasp the posterior mitral leaflet together, right? By grasping anterior and posterior mitral leaflet together, that can prevent the progression of the mitral valve prolapse. So this is indicated in those individuals who are having a high surgical risk. Okay, and by doing these repair or by doing this TEER, the mitral regurgitation can be reduced and the severity can be eliminated. So that is about the surgical treatment or the interventions in case of mitral valve prolapse. So if you see the conclusion, right, what are the various names for mitral valve prolapse? This is also called systolic click murmur syndrome, also called Barlow's syndrome, also called as billowing mitral valve leaflet. It is also called flail chest syndrome, right, or flail leaflet syndrome. right? So these are the multiple names. The most common etiology, idiopathic, and it can be associated with the heritable connective tissue disorders like Marfan's, Ehlers-Danlos, and as well as the osteogenesis imperfecta. Associated cardiac conditions which can cause mitral valve prolapses, the acute rheumatic fever, ostium secundum type of ASD, coronary artery disease, and as well as the cardiomyopathies. And this mitral valve prolapse, remember, most of these patients, they are asymptomatic. If they are symptomatic, that is palpitations. Along with that, they can have the syncopal attack and as well as the lightheadedness. And these patients with mitral valve prolapse, let me tell you that these individuals, they are having the complications like development of infective endocarditis and sudden cardiac death. But sudden cardiac death is rare. If there is severe MR with severe LV dysfunction, in those individuals, there can be sudden cardiac death. And very important auscultatory finding is mid-systolic click with late systolic murmur. And the radiation of the murmur completely depends upon which leaflet has been prolapsed. And another thing you need to know is the dynamic auscultation. What will happen to the click and murmur when the LV volume increases, and what will happen to the murmur when the preload is decreased? That is another important point you need to know. And first line investigation will be 2D echo, and drug of choice will be beta blockers. And in those individuals who have severe MR, who is having symptoms, and or those individuals with severe MR with left ventricular dysfunction, they are the candidates in whom you have to do the mitral valve repair. And those candidates whom you cannot do repair or replacement, in them you need to do transcatheter procedure, that is transcatheter edge to edge repair. So this completes the discussion of the very important topic, that is mitral valve prolapse. Thank you very much.